Now we will turn our attention to the new mental health agenda, which is our last session of the day. And this next session will address how we can leverage this particular moment of awareness to ensure all families have access to the multiple systems of support they need and explore emerging innovations that are designed to strengthen mental health care at every age and stage of life. We've assembled a fantastic mix of Ascend Fellows, parent advisor, and research and public sector leaders this afternoon. I have heard that there are multiple people who are most excited about this panel today. I'd like to invite the session's moderator, Ascend Fellow, and Dr. Mira Mani from the David and Lucille Packard Foundation to open it up.
Thank you so much. What a day we've had today, and what a great panel you have in front of you right now to help us bring it home, right? We started with hope from the very first speaker on Hope Enterprises, and then we heard from parents. We've heard from various experts about what the surveys tell us. We even heard about mindsets just now. And really at the center of it all is, how are we taking our cues as a set of leaders? What are we trying? How are we building solutions and bringing parent voice into the mix? There's just so much there that you've heard, and we're joined by extremely good panelists. And let me just tell you, I've said from the very beginning, I have no business moderating this because all of these guys are experts. But as someone who knows the least about some of these things, maybe I can ask some innocent questions, right? Joining us today is Sarah Watamura from the University of Denver. I'm just going to give you people's names because the bios are in the packet, and some of them need no introduction, I'm sure. Michael Warren from the Maternal and Child Health Bureau, Ron Lee Liao, am I saying your name correctly? Okay, perfect. Also from the Children's Hospital in Colorado, Matt Beal from Georgetown University, and Nelson, our parent advisor. So thank you so much for being here today. And you know, the structure of the panel is that we'll sort of hear from each panelist, and then I will open up a set of questions. And then we'll turn it over to the audience. We have about 55 minutes, and so we're going to try to make it through. And we really do want to hear from you as well. But as you've heard from the panelists before, just some opening framing comments from me. Mental health issues are ubiquitous, right? Finally, we're in a place where the country is talking about it, whether it's policymakers who are conservative or they're progressive. Parents are able to say what they're experiencing, and the healthcare sector is trying to put its arms around it. So really, what we have now is an incredible opportunity to have it be the galvanizing force that brings us together on behalf of children. When we think of health, we think of physical health. Traditionally, we don't really think of mental health. But now bringing this into the mix really is about whole child, whole person, whole family, whole community. And we heard this morning about joy and having a joy index and measuring well-being. And Phil, wherever you are, I think I'd like to maybe challenge you to think about how one measures well-being, given the way that the survey you all do at Stanford is really, the rapid survey is looking at the softer side of things as well. So given all of that, this is an absolutely important moment in time. So we wanted to start by hearing from Sarah about sort of what the brain science tells us and what you think how it should influence implementation in the field.
Sure. In 4 minutes, I will I will tackle this lofty topic. Nice to see so many familiar faces and so many hearts aligned. Okay, so what do we know about neuroscience from the 30,000-foot view that might be relevant here? We are learning machines. We're learning machines from the prenatal period till the day we die. We take in all the information at all levels, and we make the most of it to chart a path forward for ourselves as individuals, for our kiddos and our communities. So keeping in mind that the person is actively creating that brain and body as they move through the world, I think is a good place to start. A lot of that foundation happens early, which is why we spend so much attention on supports in the prenatal period and the first few years of life. But predispositions are not destinies. Um, Children in particular, and all of us, are very active creators of knowledge. So the best and most effective learning happens when two things are present. The child leads, and it's done in relationship. So that the person providing the information that the child is soliciting is someone who knows them well enough to provide that information at the right level of abstraction to become part of the things that they know. So looking for opportunities that we can let children lead, natural opportunities where we can let children lead and be the relational supports that understand what it is they're trying to learn about the world. This is probably true across the entire lifespan. How many baffling conversations have you had with adults, right? Where you don't understand what it is they're saying or what it is they're trying to know, and you can't meet them there, right? Versus relationships where you have conversations with folks that you know well enough to know what they're really asking, what they really are trying to understand and see. Children are no different than that. My colleague and friend Phil Fisher introduced a very important concept that has become more prevalent in our understanding of how we grow and learn, which is that quantity matters, quality matters more than quantity, and predictability might top the list there. So unpredictable environments can be especially challenging for children to navigate. And not all input that we receive is handled equally. So because of its relevance for survival, negative information is more likely to capture your attention, to be remembered, to be acted on. So we are all kind of fighting that all the time, right? This tendency to over attend to and process negative information over more positive or neutral information. So that's something else that we know about brains. So if you take all of those pieces together with my one remaining minute, I am now going to apply this to mental health. I agree. We have seen great strides in terms of destigmatization and awareness, both deep personal awareness of how much mental health matters and an awareness of how much it matters in our communities. We have so many evidence-based supports. There are so many ways that you can contribute to wellness. And we have scientific evidence to back up ancient traditions, relational supports, peer-to-peer, and of course, therapeutic alliance as ways to increase our well-being. So I think we're at the stage where we need to think about meeting people where they are in space, where they are in time, where they are in relationship, where they are in availability. So in primary care, in education, on the court, with a coach, all of those folks as people who can really help move mental health forward and bring it into something that it's okay to talk about kind of anytime. But in order to do that, we do have to attend to the mental health of our workforce, and that's not something I see talked about much. And back to our parent panel, I think mental health in the moment has a lot to do with healing from things that have happened, both in one's own lifetime and in respect of historical trauma.
Thank you, Sarah. Nelson, as a parent, can you talk with us a little bit about what it was like to navigate the system, get support for what you needed as a parent and for your child as well?
Definitely. So, and within my experiences of trying to get support for mental health and everything, just a little bit of backstory. I did get like full custody of my daughter through the courts and everything, just kind of on my own. Going through that whole ordeal did put my mental health at a strain. Definitely, not having anyone to kind of turn to or anyone knowledgeable to turn to definitely influenced like how I felt at that time. I did start to struggle with like depression and stuff. then that caused like weight gain and all that good stuff. Well, not too good stuff, but it caused all that. And given like my cultural heritage, being a Latino male, we don't really talk about mental health too much. You know what I mean? Like you're not really supposed to speak about those things as coming from my culture, Cuban American. But definitely, I guess I kind of like looked around and I spoke to friends and stuff, but sometimes you can't really speak to your family about certain issues like that because you're viewed as like weaker. You know what I mean? And it's just kind of like a cultural thing. But definitely, resources that I looked out to. I know at that time there was this program called Enlace Comunitario, and they helped me for sure. Friends, friends, just because you can't really speak to family all the time. And then also, I did have a mentor that I was able to speak to because when I was in high school and stuff, I was in Upward Bound Math and Science. It's like a STEM type of thing, and the director of there, he made it very apparent that I could reach out to him, and I guess just really having like that network of people around me just kind of made me feel a little bit more secure and a little bit more open about certain things and opening up. Um, I've gotten better at it, but at that time it was like, no, you don't talk about that stuff. But given like I know that they had mentioned that they're talking more about mental health and all that good stuff. Uh, I have come into the experience. Have come into the situation where I have to look out for my daughter's mental health. Her being a 5-year-old, she doesn't see her other parent too often, and she's going into school, and kids are honest. So I just don't want her to be in a web of situation where like someone says something to her at school and she's not gonna be able to know how to deal with it. So she's we're doing like therapy and stuff at the moment just to kind of like help prepare her for what she might be going into in the fall. And I think that's something that is very important to her just so that she's not like caught off guard and she understands the situation. Although I explained it to her, but just to like kind of give her the best supportive network that she has. You know what I mean? But yeah.
Thank you for that. In what you just described, there were several threads that we also heard before. One is you have to take care of yourself so you can take care of your children. So it's actually about both of you, and then really being able to turn to friends, turn to mentors. And this is a broader social connection that often the academic discourse talks about as social capital, right? Who do you have around you? How do you build that network of support? So this isn't about just an individualistic intervention. This is about creating communities that care, where there is compassion, and where there is faith and belief that together we can get through the challenges that we have. So thank you for saying that, in such an eloquent way. Um, Matt and Ron Lee, I'm going to just invite you both to go back and forth as you do. But, with this panel, we really want to leave people with a sense of hope and optimism about what's out there, what's working, what is their potential to embed across systems. So we'd love to hear from you about that.
Thank you. I experienced an infusion of hope and optimism. Listen to Nelson speak just now. Thank you for sharing your story. And so, as a child psychiatrist, I have been interpreting this crisis that we hear so much about around a youth mental health crisis as really a crisis of families, and a crisis of families in a state of sustained overwhelm and stress for a lot of different reasons in a lot of different places, including financial stress, including stress from their own unaddressed mental health needs, including stress from living in this atomized way that we do apart from our families and our extended kinship networks, and stress from this pervasive anxiety about the future that we all seem to be walking around with right now, and that, of course, feels most powerful with respect to our children. So I think that thinking about mental health crisis from this ecological family-based lens, you'd be confused if you walked into most places that children get mental health treatment, because their families are treated like appendages or worse, or like the problem, rather than as an inherent way to understand what's going on in the child's life and what the strengths are that are there and what the paths toward healing and recovery might be. So that's a big problem, but we're going to talk about hopeful things. So I think there are a lot of hopeful things in ways that people are starting to reconceptualize this and to go about things in a different way. And I'll share a few examples for work that we're doing here in our broader network in DC, some of our partners in the room. And then I'm really curious to hear from Ren Lee about work happening in Colorado as well. I'll give a few examples. One example is thinking about interventions for families as prevention and promotion. So we have initiatives that are going on in Head Start centers all across DC, in which we're helping to support parents in identifying their own mental health needs, their own sources of stress, and identifying and working on stress reduction, coping skills, mindfulness, therapy when that's indicated, meeting with a psychiatrist if that's necessary, as part of their child's early childhood education experience. Because parents have made the sacrifice and the effort to get their kids to a great early Head Start or Head Start center. They're also willing to make that effort to address their own mental health when it's made available and appealing and responsive to their perspective as a parent. So that's one approach. Another is that when you come to a clinic and you're bringing a child to a clinic to get help, making sure that your own mental health is addressed as well. That should be a routine part of a mental health experience, is that your entire family's health and well-being is addressed. Not every family has been as resourceful as Nelson, is what you described, of sort of taking the step proactively to get help for your daughter. It's if we make that available to families when they're worried about their child, and say we're going to help you across 2 and 3 generations because that's going to help your child to thrive. Families respond very positively to that. To Sarah's point about but other helpers as well. We do a lot of mental health services in schools, and every school that we work in, we also offer services to teachers. It's huge rates of burnout and stress among teachers, of course, and teachers really do pick up on the opportunity to do therapy, to work on their coping skills as a part of being the best educator they can. They understand that connection very clearly. And then finally, I think leveraging the kind of parent mentorship and expertise that Nelson was talking about, and helping to professionalize and support that level of peer-to-peer support is such an outstanding opportunity for us to expand the reach and depth of our systems to support families. So much informal and uncompensated work happens parent to parent. If we can figure out ways to compensate for and to build into our health systems, community health workers, community mental health workers, parent-to-parent peer support, it's powerful. And so we can talk later about some of the educational efforts that we're doing here around that as well.
Thanks so much, Matt. It's hard once you sit on the panel because you kind of want to have dialogue already. I am going to paint the picture, and I actually want to ask you a question. How many of you right now know a young person? That could be a child, a teen, a young family, transitional age youth, we call that, between teenage years and young adulthood, who's struggling with a mental health challenge, a substance use issue, addiction, trauma, right? Insecurity in their lives, right? It's almost all of us, right? It could be in your family, it could be your neighbor, it could be in your work life, right? There's nothing that hasn't been touched, I think. And Matt and I have long had conversations around how the decreasing stigma around mental health issues, I think Christian set us up perfectly, right? Watching that Bank of America account go down, finding a trusted space where you trust and the person sitting on the other side of the therapy chair, right, it understands your experience and is going to support you. We don't have that. We have a huge mental health workforce shortage. Matt's talked about some of the solutions. I hope we can talk about some of those as well. I moved from New York to Denver in the middle of the pandemic. Many of my New York colleagues are here. I arrived in Denver, and Colorado Children's actually declared a state of emergency for youth mental health. The American Academy of Pediatrics, the Children's Hospital Association, American Academy of Child Psychiatry declared a national state of emergency, and then our Surgeon General published a youth mental health advisory. You see the stats, right? 40% of teenagers feel sad and hopeless. They can't engage in things they usually enjoy in their normal teen relationships. 70% of girls, right? 25% have considered suicide. In the LGBTQ population, Native populations, that's 25 have committed suicide, have successfully committed suicide, which is painful. In our backyard, we had high school students, both victims of community violence and died by gun violence, which is now nationally surpassed motor vehicle accidents as the #1 cause of death, both between suicides and homicides. In the state of Colorado, beginning at age 10 through the mid-20s, through age 24, suicide is the leading cause of death. No one thinks about that. When we trained in medical school, leukemia was not a curable disease. Childhood leukemia is now a curable disease. Cystic fibrosis, diabetes, these were all chronic life-limiting illnesses. They still are. But you see people living productive, engaged, meaningful lives because of technology, because of moonshot ideas, right? And we feel very, I think, confidently on this panel, and I think all of you in the room, that this is also possible for mental health. But mental health has to do with security and stability and safety in your lives. So everything cannot be fixed in the mental health system. It's all of the sectors that you work in, right? Education, early childhood, economics, labor, all of it. So when I moved to Colorado, it was to answer a call. It was to re-envision what a child and family-centered coordinated system of supports could look like that invested in prevention, that invested in family-based intervention, community-based interventions. We are now building schools with school districts that have the mental health care team from the University of Colorado and Children's Hospital and the educational teams from the districts, the local public school districts, so that it is all infused within these settings. We're doing the same in primary care, same in early childhood, making those investments, and then really investing in a workforce. We lost 40% of our mental health workforce in underserved populations and needs, right? Everybody went to private practice. Everyone joined a venture tech company, right? Because you could work in your pajamas and deliver therapy on your laptop, right? And not work across child welfare, juvenile justice, right? In emergency settings, right? But we are recruiting a very different workforce and partnering from a pre-K to career way in thinking about circle time and how does that translate to apprenticeships and how does that translate into, degrees and graduate studies, if you like, but really investing in the peer workforce of families with lived experience, young people with lived experience.
Lots of questions going to come your way, I'm absolutely sure, to sort of get underneath some of that. But before we go there, would love to hear from Dr. Michael Warren about how, all of these things have policy implications. They really all have implications for how we think about funding states and what's an allowable cost and how the incentives within those funding structures really allow communities to act in ways that will build the net of support and the scaffolding. Would love to hear from you about, under your leadership, how the Maternal and Child Health Bureau is thinking about this.
Thanks so much. And I hope I can maybe whet your appetite in 4 minutes, and maybe we can get to some of those things in the Q&A. So I am from the Maternal and Child Health Bureau as part of the Department of Health and Human Services. I think importantly, we have roots in the Children's Bureau. So back in the progressive era in the early 1900s, when there were challenges with child labor, there was no organized system for child welfare. And so the Children's Bureau was established to think about all of those things and how they influence child health. And I always find it remarkable looking back over those early documents. My predecessors didn't have the words social determinants of health, but that's absolutely what they were thinking about, social and structural. Today, we are a bureau on a mission. That mission is improving the health and well-being of America's mothers, children, and families. And we frame our work around 4 key areas: access, equity, capacity, and impact. And so many of the themes I think that you've heard from my fellow panelists already are really infused in this work. Recognizing the importance of lived experiences and families as being at the center of everything that we do, and not after the fact. Having families engage pre-decisionally telling us what the challenges are, what the answers are, and how we need to design our programs. We do all this work in partnership. I came from state government in Tennessee, was fortunate to be a grantee of the Bureau. So it's interesting now being on the other side of that table. But we supply the funding. The real work happens in states and communities where folks really have the answers. I want to highlight just a few programs, and then again, hope to have some more time in Q&A. There's a lot of focus in our work right now around this early childhood space. And when we say early childhood space, we're now talking about 0 to 3, which recognizes you can't really separate that dyad, right? So we talk about mother-baby dyad, but it's really family, that family unit and how we think about meeting them where they are. You can't do that much better than going in the home in many cases. So we support things like voluntary evidence-based home visiting in every single state across the country. States get to decide where they want to deploy those federal grant dollars. States have come up with very creative ways to be able to braid that with other sources of federal funding to be able to leverage and extend those dollars further. But it's also thinking about other childhood systems. So if a home visitor, for example, identifies developmental delay, how are those early intervention systems? How are those primary care systems designed in a way that best support families? How are other systems where kids and families might find themselves designed to meet their needs? So we fund now something called infant toddler court programs, recognizing that many times those social determinants of health are strongly related to why families are finding themselves in those courtrooms to begin with. How can we bring a different lens, a lens of development and behavior to the decisions that are being made there? We're also expanding availability of care. So over the last few years, we've really grown our behavioral health teleconsultation programs in the pediatric space. And this was largely modeled after work that happened in Massachusetts and then Washington State that's now spread across the country. We're in nearly all states, thanks to, in no small part, infusions from the American Rescue Plan and the Bipartisan Safer Communities Act. This is primary care linked with the expertise that's available for child psychiatry and now maternal psychology and psychiatry as well. And then our Healthy Start program, just as an example of how we go to communities that know the answers for the challenges they're facing. This is a program that was started in the 90s to address infant mortality. It's now grown to address both infant and maternal health, again, recognizing you can't really separate the two, but it is community driven. It's driven by community action networks that design plans that are responsive to the needs of their communities. I want to share, and you'll have access to these as well, links to some funding opportunities. So related to those 2 teleconsultation programs I told you about. The one in the middle for maternal is actually open and on the street now. The Pediatric Mental Health Care Access Grants, I hope will release very soon, so keep checking that this week. And then the last QR code is for our National Maternal Mental Health Hotline. We launched this last year on Mother's Day, 833-9-HELP for moms. We know that there's a lot of focus right now on maternal mortality and morbidity. We know from our public health colleagues who do maternal mortality reviews that maternal mental health is a large driver of both maternal morbidity and mortality. And this is a toll-free service available 24/7, text or chat. So please take that back and share that with your networks, and look forward to additional conversation.
Thank you. Wow, that was a lot. And thank you for, and it's pretty inspiring to see the parallels between what we've heard today and what you just presented there in terms of what the communities are asking for and how you've shaped this. So that gives me hope. A couple of questions for Matt and Ron Lee. I'll start there. And we heard a lot from parents this morning, and then also the really inspiring quote about don't meet parents where they're at, meet them where they dream. So can you talk a little bit about how the efforts that you're involved in closes that loop, has ongoing consultation with parents so that it actually informs the work on an ongoing basis? And if there have been any key lessons that you've learned in that process?
So I can kick it off. So I was really fortunate, I think, early in my career to work with parent partners and advocates, both in the clinical space, research, and training initiatives. We learned to co-design and co-produce together. We built a children's hospital in New York together. When I moved to Colorado, I was very lucky, and I was looking for this as well. They have a very robust mental health family advisory council who works shoulder and shoulder with our clinical team, our training team, our research team to make sure families' voices are at the center, their priorities are highlighted. We have a youth action board as well and youth engagement from across the state of Colorado. And I think you can't, like, we sit in rooms and decide what's the best thing to do for a crisis and throw things on the wall and pilot programs, but without the voice of young people and their families who have the most skin in the game, right? And we usually meet parents in moments of crisis. Like, it's not, it's like, I'm doing fine, everything's good. I'll go see Matt and Ron Lee. Like, that's not gonna happen, right? So that idea of dreaming, like what their dreams are, because often they can't see beyond that day or that moment when their kid is in crisis, because you're in crisis, right? So we try to infuse that in everything that we do. There's a lot more we can do in this front.
What your question made me think of was creating virtuous cycles for families, and I think about the ways when families get effective effective help in time, it drives hope. It also drives a sense of service and wanting to pay it forward. And when we create infrastructures that allow families to, again, as I was saying before, to professionally support other families, there is a really powerful virtuous cycle gets created where if we're in a lot of our programs that were happening in Head Start centers in DC, with each program that we began, we would look to recruit a parent from that community to be a part of our team and to work with families who are at that school. And eventually we realized we ought to do this at a little bit more scale and start to train entire cohorts of families who can enter the workforce in this way. And what families are telling us as part of that training process is that the process of being treated as though they were learning a true profession, a true helping skill to other parents, it's elevating their sense of service. It's also creating economic stabilization and opportunity, sort of as you spoke of, meeting where they dream, of having the kind of job and of profession that inspires a sense of hopefulness, and also the kind of economic stabilization that is going to feed back into their own family's health as they're helping other families as well. So it's sort of thinking about the health ecology of a community. When we start to create these other inroads into the workforce, the ripple effects are really powerfully positive.
Nelson, as you've heard your co-panelists talk about this, and as you've thought about your own experience, is there advice that you would have for them and for Dr. Michael Warren about what strikes you as the thing that is, that sounds good, but there may be something in there like, I want to get underneath that. What is that really?
Okay, for sure. So I think it's like incredible what you guys are doing, like just putting it out there, because like you guys had mentioned before, it wasn't something that was talked about, like obviously some years ago, but it's so in my experiences, what I struggled with the most was kind of like finding the resources, you know what I mean? Because it's I don't know, it's not like you just like know where to go for stuff like that, you know what I mean? Like whenever I had issues, I just spoke to friends or like my mentor Curtis, but he, like, they just hear you out, you know. But like if you want like help in a sense, like in my personal experience, I just wouldn't know where to go for things like that, you know what I mean? Even like when I was going to school, I know they have like the mental health clinic and stuff, but I personally didn't want to go in there, you know, because I was like, no, somebody will see me and they'll be like, oh, what's wrong with Nelson, you know? Like I was just like, no, just kind of like keep it private, you know. But I guess, like, how can I find resources to help me, like, what in my case where I'm like shy to go places like that, you know?
How important it would be if someone that you spoke to said, well, I went to this place and they treated me with respect and I had a good experience and it really helped me.
Definitely having like someone like refer you, or someone that's gone through the experience that you might be going through, and they like refer you to a place, that would definitely like ease my like hesitation to go into somewhere.
And I think not having to know the magic door to go through or the magic word to use when you get to that door to get that service. I remember at some point in my pediatric residency, I came across a resource that government folks had put together to help families who had a child with a developmental delay get the services they needed when they showed up at the school. And it was a script of here's the words you need. And I was like, that's a helpful resource, but why do we have to even have a script? Why are the systems not structured in a way that families can address that need and they're heard and they're connected? And maybe it's not by going to that service delivery place. Maybe it's other community-based organizations. So thinking about how can we leverage the places where families go, the places where families trust. That may not be the primary care office. That certainly may not be a government agency. But how can we partner with those folks who are trusted, who know the community well, and who the community knows well, to be able to make some of those connections?
It seems to me that in more and more things are intersectional, and there is a formal and an informal system. And we really have to blur the lines between the two so that everyone feels welcomed and there is a sense of access. Also what you're all saying reminds me of what we heard about narratives in the panel just before this, and wondering, Sarah, from sort of where your vantage point, as you've heard about the models that are here and what you know to work, how can we talk about child development and maternal and child health in a way that is inclusive of mental health supports, that's not deficit based? Because that's sort of the way, there's normal development, and then if you go off course, you have these issues. But so do you have any thoughts about that?
Sure. I think I think some of these approaches are extremely promising because they're exactly what we were talking about in terms of being where people are. Scalability, of course, being a question mark. I think we have a funny way of thinking about ourselves and our relationship to each other. And we tend to, as I was saying, negative information being very salient, right? We tend to focus on othering and sort of when things aren't going right, that's the pathology over there, and I'm over here kind of safe from that pathology. It's difficult for people to tolerate having threats coming, very close to them. But sort of at any moment on any dimension, you're temporarily abled, right? Like you're temporarily not having a broken foot, right? I mean, whatever, right? I mean, if you think about the whole time of your entire lifespan, you are temporarily able to do some set of things and unable to do some other set of things. And that maybe that boundary in terms of how we feel this need to push away things that feel like pathology, which is not to say that, youth rates of death by suicide are anything that we should tolerate, but that the thoughts about wanting to die by suicide are things we have to be able to talk about, right? So those are sort of a flip of those.
I just wanted to add, I think the deficits versus strengths difference is really important. I also think another way to think about it is if longitudinal research, research that follows people across years and decades, right, is increasingly telling us that, by your 40th birthday, I don't think anyone here is 40 yet, but you'll be there soon. By your 40th birthday, there's close to an 80% chance that you will have had an episode of mental health challenges in your life.
Mm-hmm.
A period of time where you felt down and depressed, a period of time where you were grieving and had a hard time getting over it, a period of time where you were drinking too much or you were beset by panic attacks. Like these are such ubiquitous experiences. They're part of the human condition. So there's the strengths deficits thing, but there's also just like, well, of course these things happen to these. We're human.
Right.
It's part of what Sarah's talking about. And so if we're willing to talk about it as part of the human condition in every place where human beings spend time, and if every place that you all work when you go back home if it just becomes the part of doing business is asking people about their mental health, it opens up so many more opportunities to be helpful. And then if we have the right people in place to open doors, to come to people, to sort of close gaps, like I think that's where the difference making happens.
That's great. What I really think I want to do now is open it up to Q&A. And then I do have one final question for you that I was going to ask before the Q&A, but I think that question actually works better. So be thinking about a call to action, each of you, for 2 minutes. But I'd like to open it up to the audience. Yes, and right there.
Danielle Cox-Elan with the YMCA of Greater Indianapolis. Just thinking in the 2-gen capacity and of the organizations that are working in this 2-gen capacity, how we can help move that needle in mental health when resources and assets and systemic racism and all these things are at play, how we're able to help. Because I can see that you're having a mental health crisis, or I can be that support that you contact, but if I don't have the resources, how do we help that?
I think that's you. That's what you said. Yeah, that's a nice. Yeah, thank you. You know, I think none of us has all the answers, right, to this, and I think that's the place that many of our community-based partners find themselves. And so, thinking about who are those community partners who do have some of those resources, and are there ways to partner with them? And that might look like a referral. That might look like co-location. And I think we're seeing more and more examples. For a long time, it was how do we co-locate, for example, specialists in primary care. Now it's how do we co-locate mental health providers, specialists in libraries, in boys and girls clubs, in YMCAs. And so thinking about are there some of those opportunities for partnerships? Thinking also about, are there other ways to address those other social determinants of health? So are there ways to address families' food insecurity, housing insecurity, those other factors that certainly exacerbate what we've been talking about today, and connect those with your existing programs would be one idea.
Go ahead.
So I love that we pointed to Michael to start. So thank you for taking this sort of national perspective as well. They're also deeply local connections. I think that's the thing that I've learned a lot in moving states is like I had my local network. I knew who to call if I was with a family who was really struggling. I didn't know who to call in the state, right? And so understanding, I think like physical health and mental health have completely been separated in our healthcare system. Payer, care, prevention, right? There's parent-child, a completely family-child. There are no children out there that don't have caregivers, right? In some fashion, you hope in life, right? But we've completely separated adult care, child care, and the different systems. But there are these local connections. You're at a YMCA, you're often the first people I would get to know is after-school programs, community organizations, but then you need to get to know everybody else in your ecosystem, as Matt's talking about. And then how do we work together to make sure that Michael and the federal government make sure that happens at the state level and then at the local level.
Thank you. Do we have a
We have
virtual
time for
question?
one more question for virtual,
Yeah.
and then we'll let you get to your closing. So from Jen Jonica at Starfish Family Services of Michigan, could one of you talk about infant mental health, which is a 2-gen approach and has an evidence base?
Infant mental health is a 2-gen approach that has an outstanding evidence base. It's one of those phrases that the uninitiated feel shocked by. Like, you know, you can imagine the cartoon in the newspaper with the 6-month-old on the therapist's couch. That's not what infant mental health is. Infant mental health is Sarah used several times the word relational. It's an approach to mental health care that takes into account the relationship between the baby, the toddler, the preschool age child, and their parents and caregivers, and addresses the mental health needs, developmental needs of the parent or caregiver, the mental health and developmental needs of the infant, and most importantly, focuses on building, supporting, nurturing a strong relationship between the parent and child that has a few key components, that is responsive, that is sensitive, that is fairly predictable, and that really, really importantly is not perfect. It's not about sort of doing perfect parenting or just the right kind of relationship that or just the right response to a child. It's about building a real live human relationship between the parent and the child and addressing the things that are getting in the way of that.
I'm actually told that we will take 2 to 3 more questions, so I will bring the mic right here. Please
Deidre.
introduce yourself.
Deidre Johnson. I'm the CEO and Executive Director of the Center for African American Health in Denver. I was really looking forward to this conversation, as many of us were. So we've been around for 26 years. I've been there for 7. Also coming from a community with a lot of stigma around mental health, we had always been doing mental health first aid. And then when COVID hit, the urgency of doing something became very important. We are a trusted location, and what we've done is we've partnered with a new group called Therapists of Color Collaborative. They have, at this point, about 60 therapists. And we're the resource and referral, kind of that navigator backbone, and we refer to them. It's been wildly successful from the standpoint of, we offer either 18 individual sessions or 15 for family. But of the close to 300 people we've served so far, we have like a 90% completion rate, and 85% had never been in therapy before. So really demonstrating that if you pair someone up with a therapist that reflects their community, so many things fall away. Interestingly enough, some folks applaud that and some throw darts. Well, you're building an alternative, as if we're supposed to, wait a couple generations for the workforce to change. And one of the things we're trying to do is shine the light on not only how successful we've been, but how can we get systems to look at their own educational models? Because I've been working with TOCC, I've learned about so many different barriers that people who want to be therapists of color face with regard to education, certification, nothing that's surprising. And it'd be interesting to know, just kind of get your thoughts on that dynamic, because at this point, I know that if folks aren't going to a system, there's a reason. It's not because, they get so demonized. It's not because they're not interested in the service, but it's how they're being treated.
Some thoughts about this dynamic. Okay. Ron Lee?
I mean, I'm higher ed.
Okay.
We've got a bad rap at this. So, I mean, I think you're identifying a really difficult situation, which is that, in fact, we have, for example, in our training program, we have hundreds of applicants, and we take 6. It's an intensive system to train somebody to be a psychiatrist or a PhD level psychologist, right? So I think that's why, and I think that's very important to do. But I also think this enormous gap that we have in meeting need has to be met in all of the different ways. So I actually was going to throw out an idea I had, which is, how do people feel about cross-sector mental health certificates? So like something that's designed for coaches and something that's designed for teachers and you get a certificate that gives you, if nothing else, a little more sense of confidence that you are using sort of the modern language and tools that you might have. We're nodding. We feel good about that. I could build that. That's within the scope of something higher ed could do, right? To just help, build up our workforce in one way.
So to link the infant and early childhood and the certificate. One program that we started the last couple of years in DC is a training program for parents to be trained as family leaders in infant and early childhood mental health. And so that's a 9-month training program with a 2-month apprenticeship at the end of the training program. The only prerequisite is that you have been a parent or caregiver of a child in the District of Columbia. There's no educational prerequisites, and we've had effectively 100% completion rate of the training program. So, and all of our students have been people of color so far. And we're developing a workforce that speaks to exactly your question. I think we have to broaden the definition of the workforce and work on the pathways into at every level in the workforce, as Sarah spoke to. But I think the certificate idea is one that like has a lot of potential, and that really needs federal funding.
Can I add real quick? Yes. I was going to say, so we just got an announcement, and I hope this is what it was for, but from the Colorado Behavioral Health Administration to build a certificate program for peer support and other mental health, community mental health folks, potentially. So this is the local connections, right? Like we only had to come to DC to meet our local Denver partners, but working across the state, but with America Rescue Fund dollars to invest in programs, right, to train. So I think this is the kind of conversation that we should be having at all of our tables, right, in all of our communities.
Well, this certainly is cause for hope, but I just want to, as a longtime Coloradan that was a transplant to California, do a shout out to the Colorado folks on this panel and for what you're trying to get done. So I think we have time for one more question, and then I want to round up with the panel.
Oh, you want to come up here?
I couldn't see.
Okay, let me see if I can get these words right. I'm, first of all, so excited about this conversation. Thank you. And I'm going to try to slip in 2 questions, and I'm sorry. So the first, my background is in trauma and attachment. I'm a clinician. And so I find it really interesting because I've been studying attachment for, 15 years now. And I find it really interesting when I meet colleagues in the work who start talking about infant mental health, for example, or and I'm coming from Austin. There's new excitement around early relational health, right? And every time I'm like, oh, you're talking about attachment. And people are like, no, absolutely not. Nope, something very different. And it strikes me because we're kind of like repeating research and practice and calling it something different. And really, the response to all 3 of those things could really be thinking about like a trauma-informed approach to life that supports secure attachment. So I'm curious about y'all's thoughts about like those all 3 more or less being the same thing and how we can kind of align these different sectors of thought. And then the second one is you named that mental health is not a thing you do or do not have, right? It's like all of us, we all have it, we've all experienced it. And the other thing that I am curious, or I guess do work in, is equitable design. And there's a concept, right, of like designing in the margins. So we design systems for the most marginalized or those who have the most obstacles. And so I've been thinking a lot about designing schools, workplaces, all the things for the most marginalized, so trauma-informed. And curious what y'all think about how we start thinking about designing our systems for those most marginalized, rather than there's a therapist at school, but only the kids that get that therapist are supported in their mental health, right? Like thinking about the whole system being inclusive of that. That was a lot of words, and I'm sorry, but yeah.
So we'll take that question.
Had like 5 questions and thoughts and ideas in there. Did you want to take it?
Sure. Maybe on the last part, I think I'll speak from a funder perspective. I think being very deliberate about telling people who want your money that you have to design with that in mind. So it really turns on its head of give us your best ideas to give us your community's best ideas, and building in, we're trying to funding opportunities to not just check the box. I had a family member at the table for a meeting one time, or I talked to a community person one time, but I've got a community board that's driving my work. I'm responsible to answering to them. They came with the solution. I'm helping to facilitate that. And I think that gets to some of those issues you mentioned, but it has to be baked in, and the dollars have to be the strings that are attached to that. Or I think at least from our grant programs, things are not going to change.
Quick note on the changing labels and words. I'm going to tap into that narrative session, the power of words. Right? I trained in Boston and Massachusetts. We talked about attachment. Then I went to New York. We learned about serve and return relationships and early brain development. Now I'm in Colorado, in some circles, I'm not supposed to say social emotional learning or gender affirming care or anti-racist. It's really different in different pockets of the country as our field evolves. We're not doing ourselves any favors in the science side of things, and certainly not in the implementation side of things, making sure that families have what they need in the moments they need them. Who cares what the label is? I think we all agree, right? Like, I can say all these things in this room because I'm in Ascend and I'm in DC, and but that's not helping anybody, right? Like, and I brought up the suicide statistic. Doesn't help anybody, and it doesn't help anybody's kids really thrive and feel safe and like they belong if we can't say the things as they are, right? And have the same language for speaking about these issues.
Your question was super nuanced, and I'll try to speak to one other part of it, which is I don't think that it's different. I certainly any poor understanding I have of infant mental health is really based on originally on attachment. And I think that trying to channel David Willis here a little bit, I think that the idea of early relational health, that language is to make all of this more approachable to people who are not attachment researchers or practitioners, particularly in primary care and early childhood education settings, that the idea of like every interaction between a child and an adult is an opportunity to support positive relational health, and that you don't necessarily have to have a sophisticated understanding of attachment processes to be able to work in that space. I think that's the idea, but I think that they're all interrelated. And I think your question about design is an amazing question. I know Ron Lee and I will want to talk to you about it later. And I think schools are a really, really cool place to do that design in the margins, because there's a lot of flexibility outside of the healthcare system per se to do work in different ways. So I think it's a very provocative question.
Well, we've got less than 2 minutes. Thank you for that question. Thank you all for being so engaged. And it's an amazing panel. And before I thank them, I just want to do quick, rapid fire call to action. Sarah, we'll start with you.
Sure. I think we've done a great job in this session of not talking so much about individuals and talking a lot about families, but we have not done a good job about talking about context and culture. And I think every aspect of well-being is situated in time and place and community. So just a call to action to push all of ourselves to not leave that layer out.
Two really quick things. I would be remiss at this point in time if we didn't talk about the Medicaid unwinding and the opportunity that every one of us has to think about how we make sure families are connected to care. We know with this uncoupling of the Medicaid coverage provisions and the changes in the pandemic, 15 million people in this country stand to lose coverage. 5 million of those are kids. And many of those are eligible, but for a number of administrative reasons. So we all have an opportunity to play there. The second call to action is please keep the dialogue going. I've been so excited. This was not planned, but I walked in this room and I saw somebody who taught me when I was a pediatric resident, Marcia Edwards, who was running a community-based program in Nashville, who taught me things about what keeps kids and families healthy that I didn't learn in residency or medical school, things that have far more influence than what I could do in a 15-minute clinic visit. We've heard about the great program in Colorado that was mentioned and creative solutions that are happening on the ground. I will tell you, I don't know about all those things. My colleagues don't know about all those things. Folks who are making funding and programmatic decisions don't know. So please keep that dialogue open. Please never assume that we know. Please teach us when we think we know or correct us when we think we know. And let's continue that work together.
Ron Lee?
I'll be really quick. If there are young people in your lives that you're worried about or that you're not worried about, I think lean in and check in and see how they're doing. I think the kids that I've been most surprised that I thought were doing great, they're going to school, got friends, doing, after school activities. They're suffering, like very quietly suffering. And it's been a rough pandemic, and it was even rough before then. So I would lean in and just check in with the young people in your lives and reach out.
Keep pushing the topic of mental health in all conversations. Probably the most important preventable cause of mental health problems in young people and families is extreme poverty. So let's bring that lens to all of these conversations across sectors and remind people, hey, if we address extreme poverty, we're going to be improving mental health. If we improve early childhood education access, we're going to be improving mental health. There are all these unintended but really beneficial outcomes that have to do with mental health that we need to keep on people's minds.
Go for it, Nelson.
Cool. So this is just a comment to my fellow panelists. I think you guys are all amazing, and like you guys are really knowledgeable, and I just really hope to see in the near future that like anything program or anything like that that strives from this like has your guys' names attached to it, because like you guys are so knowledgeable and so amazing. Like I really want to see you like everything happen that whatever you guys are saying. You know what I mean? Like everything you guys have said in total, I really want it to become like a reality and have you guys attached to it.
Such generosity and an amazing role model. I just want to thank the audience, and your mental health matters too. So in the moments that we have, if you can close your eyes and commit to yourself that you will breathe deep and take care of your needs so you can be there for the community and yourself, that's the biggest gift you can give the people around you. And with that, I want to thank this incredible panel. I've learned so much from you. Thank you so much.